there was no improvement in the care of this patient for a long period of time. And so physicians have learned, have keep on using the same protocols, and now it's just commonly used, and it's very easy, and this is probably why. But people are interested. I mean, there was the PERT trial, and people are interested in improving the prognosis, but just it failed until now. And now new devices are provided that are very helpful, and hopefully this will change. But it will take time. First, we did build a multidisciplinary team, which includes pneumologists, intensivists, cardiologists, radiologists, in order to set up protocols of care. And then we were looking through the literature to see if anything could come to help us do reperfusion for these patients. So as soon as we heard about the ultrasound thrombolysis, we started our program. So it's a program that is centered on the ICU in the cardiology department, but which is very dependent on emergency departments. So we build a network with also the ambulance service in order to be able to receive referral patients that are brought to the ICU. They are screened, and we decide which type of treatment is most effective. We believe that pulmonary embolism is a very common disease, but in some patients, a few of these patients, you need something else than only anticoagulants, because the mortality remains high in some patients. The main challenge was awareness of all referral centers, because people are used to put this patient in the ICU, wait with the heparin, and then go on with the conventional unit and so on. And we brought something that is very new, which is a quick response for these patients. They are screened, they come, they have reperfusion, and they can go back. And we needed to make awareness of this new kind of protocols. And for this, we included the SAMU, which is the Emergency Department Ambulance Service, which, as you know, in France has a physician in the ambulance. And they were also key in order to build this network. All patients are referred to the center. Patients with a low risk EP just stay to the referral center, and we only brought in patients with very high risk patients who cannot get thrombolysis on sites for one reason or another, and patients with intermediate high risk patients. So this is a subgroup of patients. This is not so many patients. It's about 10 to 20% of these patients. For these patients also, we decide very quickly, based on the protocol, who will get reperfusion with the device, and if reperfusion should be done, it reduces the length of stay in hospital and in the ICU. So it will come in, have the same day or the day after the procedure, and then will be brought back to the center, the other center, the day after. So we only keep them in the ICU for 1 to 2 days. So what are the main benefits of acute ultrasound-guided thrombolysis? First of all, for the patients, because they get a very effective treatment, and so the right ventricle is getting better much quicker. So we see less and less patients requiring IV thrombolysis, because they are evolving to cardiogenic shock. So that's a big benefit. This is the main reason why we're using the device. The second benefit is this patient get better really quickly, and so they don't stay in the ICU very long, mostly between 24 and 48 hours, and then they can be discharged to conventional units. We know since PERT was done that we cannot use IV thrombolysis, because with 100 milligrams of Actilis, you get much more bleedings, and so you cannot use it. And of course, the device seems to be very efficient on the thrombus, but without bleeding risk, major bleeding risk. And we've been using it for several months now, and we didn't see any severe bleeding and no intracerebral bleedings. And the literature is consistent with what we see. So this is, of course, one of the reasons why we are using the device, because we cannot, in this patient, use IV thrombolysis. With the PE team, we build a protocol and we know how to select these patients. So when they are brought in, we just check all the box to see if it's an intermediate high-risk patient, if he's eligible because he has proximal thrombus, and then we will go for our perfusion for this patient. So somehow it's very protocolized, and we don't need to discuss much. Who will be selected for a perfusion? So mainly patients with high-risk pulmonary embolism if they cannot get IV thrombolysis because they have a high risk of bleeding or something else. These are rare patients. Mostly reperfusion will be using the intravascular ultrasound thrombolysis. These patients are intermediate high-risk patients. We have proximal thrombus, who have no dementia, no comorbidity, and a life expectancy of more than 1 year. We also like to see that they have right ventricular dysfunction that is at least moderate to severe with a large dilatation of the right ventricle.